With regards to research topics in CLL, there's a lot of research happening right now. We've obviously come a long way from the era of BTK inhibitors and BCL2 inhibitors. The big focus right now is how do you stop treatment? Nobody wants to be on a pill for the rest of their life, even though the pill works beautifully. And a lot of people who have blood pressure or diabetes, they take pills forever. What does that do? It controls the disease. It doesn't cure your blood pressure. It doesn't cure your diabetes, and you're okay with it. So if you don't take your blood pressure medicine and if you don't take your diabetes medicine, what's going to happen? You'll have heart problems. You'll have kidney problems. You can have a stroke. That's pretty bad. So similarly, the same concept when we talk about cancer, for some reason, it's people want to stop treatment. And that's one of the things that we faced early on is we are giving you a drug to control the disease, so who cares if it's a cancer as long as you live a normal life? Just consider this as something you would do for your blood pressure. So I think we were very successful in that approach, and a lot of patients just take a pill or 2 pills a day, and they can take it for decades, and they'll be fine. Yeah, they will have a little bit of cancer that you can find, but they're living their lives, they have no side effects, and they're perfectly functional, normal. So that was the first strategy, but obviously we also try to minimize the cost, minimize the burden of taking a pill every day or twice a day. So that's why we're developing different strategies to allow us to limit the time of treatment. And one of the strategies that a lot of folks are working on is combining different classes of drug. So you hit the cancer 1-2 approach, get into a very nice deep remission, and then stop. And that's where most of the focus is on the disease. And then we are combining new immune-based treatments with the existing treatments to come up with better, more effective regimens that you can take for a time-limited duration, 12 months, 2 years, whatever, and then stop treatment. As a result of the mutations that are developing in patients, we're also trying to develop newer drugs that can bypass that mutation, so we can keep hitting the cancer cell despite the problem with resistance. With regards to our research, we have multiple projects ongoing in combinations of different agents for patients, not just with untreated CLL. So if they're going for their first-line treatment, we are actively testing various combinations of drugs to see which one is the best. Now, all of these drugs are approved. We are just trying to figure out the best combination. We're trying to figure out the duration, which is the optimal duration. We're making sure that our patients are able to take it without having to come back and forth to the clinic as much. So a lot of times there's a misconception that, hey, are you being a guinea pig or are you being on a placebo trial? And the answer is it's very uncommon for our studies to have a placebo arm. Most of the time in cancer studies, there's not a placebo arm, and most patients will get the actual drug. Now, some cases there are placebo trials, but that's usually not the case for a lot of cancer trials. And that's what we are doing. And then, are you being a guinea pig? I think at least for CLL, guinea pigs were the ones who survived 8 years when they first went on BTK. Otherwise, all of those guinea pigs, supposedly, all the patients would have been dead. So the point is, it has to be a leap of faith at some point in time. You have to trust the science, and you have to believe that it'll work. All of the patients who went on ibrutinib would have been dead 10 years ago. 80% of them are still alive, and they're taking a pill. And they had 0% chance of survival back then. So they went on a pill, not knowing what it's going to do. And they were the first 80 humans who ever took the pill. And most of them are still alive and doing well. So the point is that it's always going to be a leap of faith. Now, that particular category of drugs is called first-in-human drugs. First-in-human clinical trials always is a leap of faith, but they're based on very good science. That's why we are offering it to you. And generally, the patients who go on those kind of trials are patients who have exhausted or explored other options. The vast majority of trials we have are essentially using treatments that we know have worked and then combining them in different ways, shape, or form. Sometimes it's a pill versus an IV, sometimes it's 12 months versus 24 months versus 6 months. So we're trying to modify and answer small questions. What is the best way forward? And this is why when you participate in a clinical trial with us or anywhere in the country, you're not only giving yourself a chance to benefit from it, but you're also moving the field forward. So somebody who walks in through that door tomorrow can also benefit from it. So our goal is to continue to keep working on it. So we have two different strategies. One is how do we best treat our patients in the frontline setting? So when they first need treatment, what's the optimal therapy? So we have trials in that space. And then obviously, if you fail treatment, what is the optimal strategy in that space? And how can we get you into a long remission with treatment that is less toxic and you can live a normal life? So those are two strategies that we are working on. And then our big push right now is to develop immune-based approaches so that we can actually harvest the body's immune system to fight the cancer, and then hopefully develop a memory in the patient's immune system so the cancer will never come back.